Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Sebastien Turcotte, a third-year anesthesia resident at the University of Saskatchewan in Saskatoon, discusses the perioperative experience of patients with English as a second language. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So I just wanted to start with a quick story. In my family, we love to talk about different expressions in French and English and how they translate a little bit differently between the two. Specifically, my mom was just telling me a story recently about how actually when she was in labor with me, when it came time to push, the nurses kept telling her to bear down. And this actually caused her a lot of stress because she had no idea what they were talking about. And she eventually turned to my dad and just said, "What the heck are these people talking about? I have no idea what they're saying." And so it's just a little bit of a funny story about how language barriers or differences in languages can really affect somebody's overall experience in healthcare without even really knowing it. My objectives for today are to explore the healthcare experiences of patients in Saskatchewan who speak English as an additional language. We'll touch on the barriers in the perioperative setting faced by patients who speak English as an additional language. And then my plan is to highlight some of the relevant tools, programs, and community services available to practitioners that work with patients who speak English as an additional language. I also just wanted to start off with a quick land acknowledgement. So I want to acknowledge that in Saskatchewan, we're on treaty land. These treaties serve to govern our relationships with Indigenous people. And we have come together today on Treaty 4 in Regina and Treaty 6 territory in Saskatoon, which is the traditional territory of the Nahiya, Cree, Saulteaux, Dakota, Lakota, Nakota, and formerly Blackfoot and Cree, Saulteaux, Stoney, Nakota, and Dakota peoples. We acknowledge the traditional homeland of the Métis and honor their contributions as well to this land that we find ourselves on now. As a quick disclosure, I have no professional associations to disclose. And given my background, many of the personal anecdotes in this presentation relate to experiences of francophone individuals living in Saskatchewan. I acknowledge that all individuals listening today have their own linguistic background that contributes to their own personal identity and culture. And this presentation is really meant to be an invitation for all individuals to feel comfortable and proud to express themselves in their preferred language. And lastly, just a little bit on me. So I was born in a francophone family in Saskatoon, like I previously touched on. My mom grew up in Quebec from Montreal, and my dad grew up in a francophone family here in Saskatoon. I attended Francescois Elementary School in French immersion, Francescois Elementary School in the city here called École Canadienne Française, as well as a French immersion high school in Saskatoon. I was a member of the FrancoDoc organization, both at a local and national level in medical school. And so at the local level, our group mostly focused on medical terminology in French and organizing workshops for medical students to be able to practice some of their French language skills in a clinical setting. And this actually expanded to all professional healthcare colleges. And so we had nursing and physio and other Francophone students involved as well. More at the national level, this group was involved with promoting the French language in the clinical setting, sort of on a systemic or national scale as well. And lastly, like I previously mentioned, I'm a proud member of the Francescois community in Saskatchewan. And for those who haven't really heard that term before, it sort of symbolizes the Francophones living in Saskatchewan here. And down at the bottom of my slide, you can see a little flag there that represents the Francescois community that I grew up a part in. Now, the I've got multiple clinical encounters that have sort of inspired me to discuss this topic with you all today. But one that always sort of sticks out to me is a clinical encounter during my CCU rotation. And so what had happened was a 64-year-old male had presented to RUH with chest pain from the periphery. He had recently moved to Saskatchewan from rural Quebec for work. He was a francophone patient and he spoke very little English and didn't really understand too much English either at the time. Previously, he had presented to a peripheral medical center following the sudden onset of chest pain roughly 6 hours ago, but no one at this center spoke French. And of note in his background history, he had recently missed a scheduled cardiology appointment for an assessment of ongoing chest pain that he had had for about 3 months. Unfortunately, he mentioned to me that the reason for missing this appointment was due to a miscommunication with the cardiologist's office. And since he had to travel from his small community to one of the bigger cities in the province, this had sort of been lost in translation on him and had missed his appointment. And so the reason why he was coming in and presenting today after 3 months of chest pain was that eventually he just couldn't really handle it anymore. He was very concerned about this chest pain that he was having. And all of a sudden it had become much more severe to where he decided he needed to seek care. And so the patient was transferred to Saskatoon from this peripheral center following an initial assessment. The EMTs had provided me with a rhythm strip that showed, perhaps some ST elevation in leads 1, 2, and 3, and so they were concerned about an anterior lateral STEMI. So the patient had actually come in as a STEMI alert. He was given nitro spray opioids, ASA, and it was our job to sort of determine if, was this really a STEMI and did this patient need to be rushed to the cath lab or not. His symptoms did persist despite getting some of this medical therapy already. And so in my initial bedside assessment, I had initially spoke to the patient in English and started to gather my history of presenting illness. He appeared well. He didn't appear to be in too much pain, but kept describing this gnawing feeling in his chest that he just couldn't really get rid of. He was really pleasant, but seemed uncomfortable in the emergency department. He wasn't really familiar with the surroundings. He didn't know anybody there. He was alone. He didn't have any other family members with him. And he appeared quite confused by some of the questions that I was asking him and had difficult formulating answers in English. And so I actually, picked up on his accent eventually and just asked if we could switch the conversation to French. And he was very open to this because it allowed him to properly outline some of the symptoms that he had been feeling that he hadn't been able to do either in the peripheral setting or back at RUH when we had seen him initially. Even though I would say my medical terminology in French is maybe not the best, he was better able to understand some of the questions that I was asking him and the context as to why they were being asked. I was able to build some rapport with him more efficiently and actually get to know him a little bit better, and this allowed us to develop more trust in our relationship as I was asking him questions. And I was able to properly decipher between chest tightness versus pressure that he was describing in French. In comparison to, he could only really use the word pain to describe his symptoms in English. And what had actually ended up happening was that this was more of a chest tightness and palpitations that the patient had been feeling for so long, but he had no way of actually describing it in English. And then subsequently, I witnessed how the patient again was struggling to understand questions asked in English by the fellow attending that had come to the bedside to join me. And these were the same questions that I had asked in French, but the context of the patient or the context of the questions and therefore the answers that the patient was giving was very different compared to when I had previously asked them to him. And so overall, I think, the patient did well. He didn't end up having a STEMI. It was likely secondary to a left bundle branch block that he was having some of these symptoms. But it really just outlined to me how when patients are able to express themselves in their own language that they feel comfortable in, that they're actually able to properly describe their symptoms, build better rapport with the staff that they're working with, and overall have a slightly better healthcare experience. And so that was sort of the inspiration for my talk today and the importance of language. So language is closely linked to the identity and culture of an individual, as well as to the relationship of their community. Language is a major contributor to individual or group socioeconomic status, and as a result, relates to health outcomes in the patients that we're serving. And as I previously touched on, the provider and patient interactions in a shared language can improve trust, relationship, and break down any cultural barriers that might be between the provider and the patient. Now in Canada, we have two official languages, French and English, and over 75% of the population's first language in Canada is English, with French being second at 21.4%. And the percentage of English and French bilingualism in Canada is roughly 18%. And now in Saskatchewan, those numbers in terms of the number of French speakers or francophones in the province is lower. It's roughly 1 to 2%. And only 4% of individuals in Saskatchewan are bilingual in both French and English. And I guess just as a personal note, although the percentages seem a bit small here in Saskatchewan, I'd say we still have a thriving francophone community and individuals who go about, most of their lives speaking French for the most part. And I think as one of the two official languages in Canada, it's important that we offer as many services as we can to those individuals as well, even if it is a smaller percentage here in the province. In terms of non-official languages, up to 41.2% of Canadians can conduct a conversation in more than one language, which I think is really impressive. And actually, 4.6 million Canadians predominantly speak a non-official language at home, so outside of English or French. And that's 8.1% of Saskatchewan's population as well, which is very impressive. Mandarin and Punjabi remain the two languages, other than French and English, that are spoken predominantly at home. And 7 in 10 Canadians with a mother tongue that is neither English or French are able to speak one of the two official languages at home. But that still leaves, almost 30% of Canadians who don't speak an official language who aren't able to carry a conversation in English or French. And I think that's something to always keep in mind of when we're working with patients in the clinical setting. And then lastly, in terms of Indigenous language, there's more than 180,000 people in Canada who speak an Indigenous language at home on a regular basis. And actually, the province or territory with the highest level of bilingualism in Canada is Nunavut. And there are greater than 70 Indigenous languages spoken in Canada, with Cree and Inuktitut are the main Indigenous languages spoken in Canada. So that was a little bit of a background on sort of the state of languages here in the country. And now I'm going to sort of switch gears a little bit and touch on their effects, how this can sort of affect language barriers in healthcare. And so the first topic that I wanted to touch on, with the increasing number of refugee and immigrants, Canadians who are or permanent residents entering the country, I thought it would be important to touch on this just from a more global scale. And so this was a study done in 2016 out of the US during the Syrian war. And as the US was welcoming more Syrian refugees into the country, I thought this was a really pertinent study to touch on. The three main themes through this qualitative study that the researchers found in terms of refugee health experiences in the US, the major one was miscommunications between patients, providers, as well as the system as well. And so they found that there was a huge language barrier and lack of interpreter services offered to these patients. This often led to a lot of missed appointments, delays in care, and really a sense of isolation that these patients felt due to these miscommunications that they were experiencing. These patients had a lot of challenges navigating the health system in the US, whether it was, like I mentioned, finding health appointments or understanding why they were having certain diagnostic testing done or why they were given a certain diagnosis or treatment. And this would often lead to varying trust levels and satisfaction in refugee patients. And often one of the main issues cited by the authors in this paper was the cultural differences between patients and providers in terms of the treatment goals and options that were provided to them. And so a lot of these patients felt that some of the more cultural treatment options that they may be used to from from Syria wasn't really offered to them here, or wasn't really accepted as a viable option by healthcare providers in the US. I thought this was a really interesting article, actually based out of Regina, um, outlining some of the healthcare experiences for new immigrants in Canada. And so again, this was another qualitative study exploring the experiences of immigrant patients in Saskatchewan. They found that with language barriers, they were more likely to experience medical errors, delays in diagnosis, or suboptimal care. Migrant patients were more likely to develop poor relationships with their providers. They developed mistrust, and they were unable to communicate their health needs, and often experienced racism or discrimination in the healthcare setting. One of the main issues that was raised by the authors in this paper was the rushed appointments that patients felt that led to poor communication and a lack of advocacy for themselves or their family members that they were working with. Another interesting point was that confidentiality was often overlooked when translation services were required. And so oftentimes patients would um, have to have somebody else, whether it was a family member or more of a professional interpreter service, join for the conversation. And right off the get-go, this always breaks confidentiality for patients. Um, I remember as well as a young R1 on my general surgery rotation, having to meet a patient in the emergency department, where, as many of you are aware, is quite overrun right now, and having a discussion with a patient in terms of their symptoms and history of presenting illness right in the waiting room. But actually, the patient spoke Arabic and very little English, and in this setting, he had no family members with him because his wife was looking after his kids. And he actually asked just another patient in the waiting room if it was okay if he could help translate for me so that I could help gather history and provide care for him. And so confidentiality is one of these things that we often take for granted, I think, as uh, individuals who speak the same language as our healthcare providers, but this isn't always the same for um, patients who do not speak English regularly. And so often there were delays in cares caused by inability to adequately communicate patients' urgency as symptoms. And so this was brought up sort of from an emergency medicine standpoint, that patients would have to often come multiple times to the emergency department before receiving the adequate care, whether it was urgent surgery such as a cholecystectomy um, or other issues. And often these patients were viewed as uneducated or from a less advantaged economic background, even though that may have not been the case. And then overall, this just leads to a breakdown in the therapeutic relationship with providers and patients. They lose control over their own health, and it often leads to frustration, anxiety, and dissatisfaction with their healthcare experience. Zooming in more into the perioperative setting, I thought this was another really interesting article from the US that described the perioperative outcomes for total knee arthroplasty patients who were non-English speakers. And so this was a retrospective review from a high volume center in the US that did multiple of these surgeries a day. And groups were separated between English preferred and non-English preferred. And then the non-English preferred group was actually also separated based on request for an interpreter or not, and whether they had a family member or somebody else close to them that could help provide interpretation services for them. And it was interesting that patients who requested an interpreter often experienced a longer length of hospital stay, um, and but the expected rates of readmission, revision, or manipulation under anesthesia, if there were any issues with their total knee arthroplasty, was actually lower than English-speaking population. And the authors had uh, surmised that this could be suggestive of a lack of communication in terms of expectations for their recovery and when to return to seek care. as either these patients just didn't understand what sort of symptoms to look out for to come back and seek care, or if that was just never communicated to them in the first place. And then this was another great paper. It was an integrative review from Australia and described the perioperative experience of ethnically diverse older adults. And so this paper takes a little bit more of a broader view of the cultural aspects that affect patients and their perioperative care. But they do mention, or they did touch on a lot of language barrier and issues around language that also affect their care. And so they came up with culturally relevant themes or considerations to improve a patient's perioperative experience. The first was appropriate decision making and allowing patients the autonomy to do so. And so patients, when were in the situation where they were able to properly communicate some of their symptoms and their concerns, this improved the trust that they had with between themselves and the provider. And the authors touch on that this was often improved when the provider could also speak the same language as the patient. And so this improved their perioperative experience and outcomes, and also improved their understanding of the procedure that they were undergoing. Also really important to include family members or other members who are close to the patients, as decision making for many individuals are influenced by cultural or family factors. And so having the time and opportunity to do so was really a huge benefit for patients. And often patients would defer translation either to family members or friends that were there with them rather than going with a professional interpreter, just because they knew that that individual would know them a little bit better and understand their values, both from a cultural and personal perspective, a little bit better. And again, just acknowledging the cultural views and beliefs of patients often led to an improved trust between patients and their providers. Further, when patients were provided sort of accurate, timely, understandable information, this often improved the experience that they had in the perioperative setting. And then also, in a little bit related to the last study that we discussed, it was really important for patients to have the autonomy and the proper education in terms of discharge planning and when to return to care. And so often patients would want caregivers or other family members at the bedside, also receiving some of the education around the time of discharge to help them in terms of their recovery. And it was really important that this discharge information was understandable both to the patients and their family members. And so having them at the bedside was just a very, very big benefit for them. And then one thing that they did touch on as well was having legible prescriptions, whether it be in a different language or just in writing that was understandable for the patients, so that they could truly understand if there was any medications to take in the post-op setting, that they could do so appropriately to help with their recovery. And then again, this was just another systematic review that touched on some of the language, the association of language barriers with perioperative and surgical outcomes. So this was a systematic review of the literature done in the United States as well. And they found that low English proficiency was often associated with reduced accessibility to timely surgical care, increased length of hospital stay, and worse understanding of discharge instructions. Again, the authors note in this study that low English proficiency was not necessarily associated with adverse clinical outcomes, such as unplanned readmissions, postoperative complications, or mortality, which I think is reassuring to me that patients aren't experiencing ill health effects due to some of the language barriers that they might be facing. However, there are a lot of parts of a patient's experience that we can still improve upon, given some of the
I don't
effects of
know
language
them.
barriers. And then I think one of the areas that we as anesthesiologists might see the effect of language barriers the most is up on the labor and delivery floor. And so this was a great paper sort of describing some of the barriers or associations that laboring mothers would experience due to their language barriers. And they touched on the fact that pain expression during labor often varies through multiple cultural, personal, and medical factors, and this can be very different for different individuals. But they found that immigrant women were shown to have less access to educational materials leading up to their labor. And so this increased the stress prior to their labor regarding the management for both pain as well as how their child was going to be looked after their delivery. And there was also the belief or expectation of negative attitudes of healthcare personnel towards the cultural differences or language barriers that these patients might face. The authors found that women experience language barriers had a greater expression of pain due to the decreased control over their pain. And so what they mean by that is that patients often felt that they had to go out of their way to really show providers that they were experiencing pain to get the appropriate analgesia that they were hoping for. And that there's a difficulty to adequately express their pain, which led to the risk of providers underestimating their pain. Lastly, the authors also touched on the fact that the experience of patients was improved when they did have a support person at the bedside with them, whether that was a family member, the patient's partner, having somebody else who understands their cultural background, what they're trying to express to the healthcare provider is a huge benefit for patients when they're going through labor. And then I think another issue that presents itself with language barriers is the idea of consent. And both from an ethical and professional standpoint, as providers, we always do our best to obtain properly informed consent so that patients can always have the autonomy that they deserve in their healthcare. But this is often affected by language barriers with patients. And so these authors investigated the use of a preoperative PowerPoint presentation with the use of an interpreter prior to a cholecystectomy. And so the way that they did it was this was done in Texas. And so they had English-speaking patients as well as Spanish-speaking patients. And so prior to their surgery, both sets of patients received this PowerPoint presentation, but those who spoke Spanish also had an interpreter helping them understand some of the materials. And they attempted to account for confounders such as income, education, employment, some other socioeconomic factors that might also be at play. And the goal was to improve patients' knowledge of the procedure, risks, indications, as well as obtain properly informed consent prior to a laparoscopic cholecystectomy. Unfortunately, the English as an additional language group scored lower on the post-presentation quiz that the authors had provided following the PowerPoint presentation. Specifically, they demonstrated a decreased understanding of the potential risks of the procedure, what the complications might look like, as well as when to return to care. And so I think this sort of touches on the theme of what we've already discussed a little bit in terms of that providing proper communication to try and help these patients understand, when it's appropriate to return to care. And then lastly, I just thought this was a really cool QI project out of California. I think it was the University of USC. And so this was performed both in the perioperative setting as well, or sorry, in the preoperative setting, so in their PAC clinic at the university, as well as on the day of surgery. And so in the PAC clinic, an information package was printed off and provided to patients in various languages, and usually their preferred language, outlining some of the anesthetic assessment, the process or expectations that they can look forward to both in the PAC clinic as well as on the day of their surgery. And then at the bottom of the slide here, there's a little card that some of the anesthesia providers would wear that outlined or communicated some of the main safety themes that always come up in anesthesia. And so the first one on the left, I'm not sure if you can see, it's a different translation for breathe or breathe deeply, which is something that we always ask patients to do when we're pre-oxygenating. The middle column has different translations for the word pain, asking if patients are having any pain when they're waking up. And then the last one here on the right is just that the surgery is finished. And so reassuring patients that they're waking up, that they're safe and that they're going to be heading over to the recovery room. And what this did, the authors just mentioned that it improved the overall experience for patients. They felt more comfortable communicating with providers, and also increase some of the safety factors surrounding surgery, just because providers were better able to communicate with patients. And the initial reason for this entire QI project was that what's unique to anesthesia is that we often don't have access to interpreters in the areas where we work because often they're not able to join in the OR due to safety um, concerns. And so this was one way that allowed anesthesia providers to communicate a little bit more effectively with patients. And so we touched on a lot of different aspects of the literature, and I just wanted to sort of provide a quick little summary again. But there's a lot of factors that are affected by language barriers in the clinical setting. We touched on a little bit about migrant or refugee health and the experiences that they may face. Perioperative outcomes, although some of the major consequences or that patients might face, such as post-op infections or other issues, aren't as big of an issue, but their overall experience is decreased when there's a language barrier involved. Informed consent is a major issue that I think requires a little bit more optimization when we're working with patients faced with a language barrier. And then lastly, of course, from the labor setting, appropriately assessing patients and their pain is something that's really important, and takes more time and more thought when we're working with patients who have a language barrier. And so now I just quickly wanted to touch on some of the services that might be available to providers to help when they're experiencing with patients who have English as an additional language. And so the first is the SHA translation services. This can be reached through Switchboard, or I have the phone number listed there on the slide. They offer interpretation services available in over 200 languages and is available 24 hours. In terms of interpreter services, I found a really interesting article based out of Boston in Harvard that sort of looked at some of the interactions between anesthesia providers as well as interpreters in the clinical setting. And what they found was that it's actually not the role of the interpreter to try and fill the gaps in knowledge translation when they're translating from one language to another. It's still, the responsibility still lies on the anesthesia provider to provide all the information necessary so that patients can make informed decisions in terms of their care, and that we shouldn't be expecting interpreters to fill some of those gaps for us. They also mentioned that interpreters require additional time to relay some of the information, as a lot of the expressions or some of the medical terminology that we might use in English doesn't translate as effectively in other languages. And so it's really important to always keep in mind that interpreters might need a little bit more time to properly sort of explain or translate effectively for patients. It should also be noted that interpreters' level of medical or anesthesia knowledge varies greatly, and there's different certificates that interpreters can obtain. However, their background in terms of medical knowledge and anesthesia is very different, and so it's important to make sure that both the interpreter understands exactly what is being explained to the patient, to ensure that nothing gets lost in translation. And then again, I think this is a major theme of my talk, but the consent process varies significantly amongst providers. And so one thing that was mentioned that a lot of interpreters noticed was that the level of detail or understanding for patient level, education level. And what I mean by that is the information provided, what sort of education level are we discussing this at? And so making sure that the information that we're providing to interpreters to be able to translate has to be at an education level appropriate for the patient as well, and that the level of detail should be that patients have all the information required to make an informed decision. And then lastly, I just thought this was really interesting, but visual aids, can significantly improve patient understanding of when some of the concepts that we're providing to them are being translated. From a francophone perspective, there's an organization in Saskatchewan called le Réseau Santé en Français de la Saskatchewan. And the goal of this organization is to improve some of the healthcare experiences and opportunities provided to francophone patients in the province. And so some of the services that they offer include La Ligne Empathique. And so this is a mental health service for francophone patients seeking counseling or acute mental health care needs in the French language. There's the accompagnement dans le système de santé, and so this is an accompaniment service where an in-person translation service can be provided for patients attending medical appointments or seeking specialist care. And I think one of the areas in anesthesia where this could be really beneficial for francophone patients is at the PAC clinic. And so if you know that you have a patient who speaks French or who would prefer to um, have an experience in French, we could reach out to this organization to help organize a time for them to have somebody join them and provide translation services. And then overall, this organization helps promote healthcare in French by facilitating workshops or webinars, promoting various health topics within the scope of French culture and language. And then lastly, they love to collaborate with Francophone professionals and organizations to expand healthcare access in French for Francophone patients in Saskatchewan. There's also the Reach Clinic in Saskatoon, and so this is the Refugee Engagement and Community Health Clinic. It's a collaborative partnership with Global Gathering Place, the College of Medicine, and Saskatoon Open Door Society. And they offer primary assessments for refugee patients who are new to Saskatchewan. They also offer diagnostic imaging labs, pharmacy services, and some of the follow-up appointments can either be with a physician or nurse practitioner working at the clinic. They also provide TB prevention and control and can refer to specialists sort of as needed. For Indigenous patients, there's First Nation and Métis Health, which I'm sure many of you are already aware of, but I just wanted to highlight some of the amazing services that they provide as well. And so they're located in Saskatoon, Regina, and Prince Albert. They provide elder cultural support, advocacy, translation services or interpreters as needed, coordination of services, whether it's transfer between different hospital sites or helping patients seek specialist care as needed. They provide education both for healthcare providers and patients in the healthcare setting. And there's also specifically the Maternal Care Center and the Indigenous birth support workers provided on the labor and delivery floor for any patients that might request it during their stay on L&D. And then lastly, I thought this was a really cool website that was brought up to me by one of our colleagues in the department. It's a really easy website to navigate. It's called laborpains.org. And I just highlighted the circle there at the top. This is a screenshot of their website. But there's a tab there at the top that provides all the information in terms of labor expectation and different forms of pain management. And it's translated in multiple different languages. And I did have a look at the French video. It's actually quite good. And the information is very succinct. It's at an appropriate level for patients to understand. And I think could be a really interesting tool for patients up on L&D as well. So that was everything that I had for you all today. Just a few little take-home points, I think, at the end of my presentation here. Allowing patients to express themselves in the language of their choosing improves the clinical experience as well as their outcomes in the clinical setting. And I would say that even just social language engagement makes a huge difference. The picture here is just a little pin that I wear on my lanyard that I hope that patients can see sometimes. I think I try to be proud in the fact that I'm able to speak French and that I'm able to have that conversation with patients if they feel more comfortable expressing themselves in French. And even though I'd say my medical terminology in French is adequate at best, providing that opportunity for patients can have a huge benefit to their experience in the clinical setting. Language barriers, of course, as we touched on, increase the challenges in obtaining proper informed consent. And so it's really important to take the time, use the resources available, whether it's family members at the bedside, interpretation services, visual aids, whatever it takes to try and help improve some of the consent process for patients so that they're able to properly understand some of the procedures that they're about to undergo is truly important. And then lastly, there's multiple systemic and community resources available for practitioners. I highlighted a few in my talk today, and I'm sure there's lots more out there. But there is help out there to try and help navigate some of the language barriers between providers and patients. And so part of my goal for today's discussion was I'm happy to answer any questions that anybody might have, but also if anybody has any personal anecdotes of their own that they'd like to share, any other resources that they use when they're working with patients who are faced with a language barrier, I would love to hear from you all. Otherwise, thank you so much everybody for listening today. I know this is the last grand rounds before the Christmas holidays, and so I just wanted to wish everybody a happy holidays as well. Thanks.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.